Welcome to Podcast by TechNation. This is a series of podcasts focused specifically on the biomedical and HTM industry. Episodes are added monthly. Listening to each episode is eligible for one continuing education credit from the ACI. At the conclusion of this episode, you'll be able to access a link that will take you to a quick survey. You'll be able to download your certificate once you submit the survey. Before we begin today's podcast, I'd like to invite you to save the dates for our upcoming HTM Mixers. We'll be in Milwaukee on July 14th and 15th, and in Kansas City on November 9th and 10th. Please visit htmmixer.com for details, registration, and our steps to a safe and clean meeting environment. Podcast by TechNation would like to thank our sponsor, Accruent. Accruent's intelligence for the built environment aims to improve operational efficiency, regulatory compliance, and the quality of patient care, and to drive gains in performance and availability of healthcare assets, including facility and biomedical equipment. For more information, please visit accruent.com. In this episode, we are joined by Al Gresh, David Brodigan, and Mike Myers. Gentlemen, you may begin whenever you are ready.
Hello, everyone, and welcome to HTM Insider. I'm Sherelle with Multi Medical Systems, and we're excited today to have Perry Kirwan, the VP of Clinical Engineering at Banner and Intech. So welcome, Perry. I know you're very well known in the industry, but it'd be great if you could just give us a little introduction for people who might not know the infamous Perry.
Hello, everybody. My name is Perry Kirwan, and I'm the Vice President of Technology Management and Tech for Banner Health. Banner Health is headquartered in Phoenix, Arizona. We operate in 6 states, predominantly in the Southwest. We have over 30 hospitals. I support an asset base of over 220,000 pieces of medical equipment with an asset value greater than $1.8 billion. And I'm happy to be here today.
We're happy to have you. So, the topic is right to repair, and in California, legislation is coming up pretty quick. So we're excited to see your views and what's happening in your neck of the woods. I know you have hospitals in different states, but we also know you've been through a lot of COVID lately and a lot of issues around right to repair. So we're eager to pick your brain. So let's just start off by asking you, what is the right to repair?
What I would say first and foremost to me is that the right of repair is a debate ultimately about property rights and what it means to be an owner versus just a user. I think what's happened, and this is just my view of modern debate, is that it's unfortunately become an oversimplification of a highly complex issue, right? And we try to take something with a lot of complexity, reduce it down to 30-second sound bites in a manner that unfortunately sets up camps, right? So you have one side entrenched in and another on the other side, and now we're fighting with each other. Sometimes I wonder if we remember what we're really fighting for. What I would tell you as a leader of a fairly large hospital-based system and also a leader of that service team, really all we're trying to do at the end of the day is really what's best for the patient. And in hospital vernacular, that's the quadruple aim. It's about quality, cost, the experience that the patient gets, and also the experience that the clinician gets. And I think with that, there are barriers that actually get in the way for us being able to do that. Certainly, if there's any kind of restriction on service information, parts, and the like, right, that hampers our ability to deliver. With that said, this is to presume that if you're on the original equipment manufacturer side of the argument, right, that everything that they say is kind of bad. And I don't necessarily espouse to that belief either. I think the OEM has all of the rights to want to understand what something like that looks like and actually what it takes, right? Because again, these are very simple things to say. They're a different thing in practice to execute. Um, so ultimately, I think what's required here is we have to go back to a collaboration between the OEM and non-OEM entities, right? And that includes independent service organizations as well as hospital operators in the process, but do so with the quadruple aim in mind.
So I know you've been in clinical engineering for quite a few years. One of the best stories I've ever heard of how you became a clinical engineer is your story, Perry. So if you don't know Perry's story, I suggest you ask him someday. It's a great story. But when did you see the division really come about between, a manufacturer and an owner? And when did you actually think, wow, this is an issue? Can you put a year to it or pinpoint maybe a time frame?
You have to go back really to automobiles. And where this first raised its head really in a legislative form was back in about 2012 in the state of Massachusetts, right? And the issues were very similar to what we're grappling today with medical devices, right? It was all about being able to have the right to choose options, right? And to be almost allow the environment to have options even to choose from when it came to automotive oriented repair. The cell phone industry kind of got involved with this, and we had cases with cellular providers along with Apple Computer involved in it, right? And that led to things like the Digital Millennium Copyright Act, right? And various things that we did around that. I think a lot of people became involved with right of repair around the John Deere case, right? And probably are aware of cars and cell phones and all of that along the way. But the John Deere one was rather popular because it was ugly, right? It had a lot of vitriol to it. It went back and forth and the like, right? But it ultimately resulted in that exemption. And frankly, it didn't seem to be that much time afterwards that then we had the FDA workshop, right? Claims were being made that anybody other than OEM-based service was actually creating patient safety risk in there. And I would say that probably most of us, right, if you hadn't heard anything and been following the conversation to that point, this one certainly got your attention because this got very, very close to home. Objective evidence, right, was analyzed, and it concluded that, whether it's the OEM or whether it's the third party or a hospital operator, servicing of medical equipment, right, is of high quality. And it really doesn't matter what among those entities and who among those entities that the services actually are occurring by, right? And so that continued availability, right, of all of these service options, right, is the critical component actually of functioning US healthcare systems. I think that's a really important conclusion. The other thing that I thought fascinating about the outcome of that workshop is that there was I won't call it an edict, but certainly what the FDA did was kind of created this notion of collaborating communities. Unfortunately, two of the big trade alliances that represented the OEMs, along with some of the OEMs, actually just withdrew from the collaborating communities at all. And I think that was terribly damaging in there that they did that, because the reality is that we need them to be part of that solution.
A lot of OEMs come knocking on your door to sell you equipment, right? The latest, the greatest, the upgrades.
Sure.
When they're wanting to give you a service contract and they're wanting you to sign a long-term agreement for service, what are your thoughts? Like, do you jump in? Do you take it back? Do you think about it? What's your pushback to the OEM?
reality is, right, as a hospital, we're a care provider, and we're going to buy equipment, right? It's the tools that you need in order to deliver patient care. I think the way that I look at that, though, is that we always start off, I mean, any sales human can peddle what they wish, I guess. I'm not off put by that. I expect them to, do whatever it is really that they do. But I think they have to understand really in working with us, what perspective we come with, and that is we're looking out really for the best interest of the patient. And we do that within a framework of operating in hospitals, which in their own right are extremely highly regulated, and they're regulated differently from those that manufacture widgets. What I mean by the patient-centered aspect is that, so first and foremost, we go into a discussion knowing before we even started really what we think the best answer is to that. And not from the perspective of Perry Kirwan, it's the perspective of the patient, right? And if I have the personnel, if I have what I believe are the skills and training, we're going to say, hey, we think we are the best option for the patient in that scenario. So OEM, what can you do from that premise to help support us to be successful? Because if we're successful, the patient's going to be successful.
What happened during COVID when there were travel restrictions and you weren't able to get, like on the higher end equipment, right? You weren't able to get the OEM to show up to service.
Yeah. So
what happened then?
Yeah. So what's interesting about that in Banner anyway is I won't say we had zero occurrences of that, okay? Because we had people that and firms that attempted that. I'll just use the word attempted. Fortunately, what we got, I want to speak on the positive side of it, is that most people didn't interact with us like that, right? But that said, there were some practical realities to that. There would be times where we would need them and we could not get them for various reasons or another. And we had to figure out creative ways to get past that, okay? So it's a different kind of restriction, because one restriction would be is we all know the right answer, but we're refusing to provide it, right? That's the most toxic version of it, right? And although that one happened to me only once of all the occurrences that we had, once is too many. And I know that colleagues around the country experience that more than once, right? So I'm not trying to say, oh, the situation didn't happen or it's not like that, right? Because it is. We were fortunate just not to have to go through it too often.
You think that's because of a bigger health system?
It could be because we're a bigger health system. I would like to believe that it's because of the way that we posture ourselves with our suppliers. And this relationship that we're trying to establish with them happens long before we get to needing to know, I guess, what the service strategy is going to be, right? We handle it in the acquisition phase. And so these discussions happen really prior to acquisition. And it's all about really setting company expectations of each other.
If you were a small hospital, would you use the same strategy if you didn't have the buying power?
Well, we would attempt to. I think the question is, what's going to happen? And I actually can say that with at least some knowledge of rural healthcare, because there's a fair number of our hospitals that serve rural communities. It's just the reality. Fortunately, they're tethered to a larger organization, and probably, I mean, there's, I won't say no doubt, but let's play the percentages, right? They enjoy an advantage of being tethered to a healthcare system. So with that in mind, right, and knowing how rural healthcare works, let's say if you were an independent, and I have the opportunity to be able to even service some independents out there. This is a challenging situation. And some of the things really, I think, that are being debated around right to repair actually, I would argue, affect rural healthcare probably the most, right? Some of these policies in there, if enacted, right, can really hit them hard and can be very, very restrictive.
Well, because
So
a lot of them don't have actual maybe clinical engineers on staff 24/7, and they're relying
um,
on facilities, and that negotiation of the contract maybe falls to somebody who doesn't have the expertise that you did. So this is a great takeaway is, being educated on your supplier and negotiating those terms up front on your expectations. I think that's great, Perry.
yeah, well, and the thing that I would conclude about rural healthcare is I think the U.S. healthcare system in general is failing rural healthcare.
So if I was to ask you the one big myth that's in the right to repair and the act and the legislation that's coming up, if you could just say, hey, this really isn't true, and be standing on the floor of the House to give your opinion, what would that myth be?
Hmm. Well, I'm not so sure that there's one big myth. I
Okay.
think there's several myths
Okay.
in there.
What are they?
And we talked about them kind of in the beginning a little bit, right? I think one of them is that we have patient safety issues in there, right? And that somehow, anything other than the OEM is the wild, wild west, right? And so, got a bunch of unregulated people out there doing God knows what to these devices. And because of that, there's going to be patient harm. The counter to that is that didn't actually happen. The FDA evaluated evidence to that effect and found no evidence of it. I think a lot of things we hear too is that, oh, people that are proponents of this, you're just a solution looking for a problem. Well, I would give you COVID-19. It was interesting you asked that about that, but COVID-19 just blew the lid on all of that, right? Because now all of a sudden we had the perfect storm of circumstances where some of this policy, right, and protocol out there got exposed, and it got exposed in a big way, right? So that's obviously a myth. Trade secrets and proprietary information, intellectual property. And this is actually I see both sides of this one. What I would say, right, if being on the defense of right to repair, is that OEMs actually work on each other's stuff. So if it was really about trade secrets and proprietary information, at least as it leaks into the service side of the discussion, that pretty much undermines that a little bit, doesn't it? Right? Because if they can do that, it makes you wonder, well, okay, then why can anybody else really do that at this point? And then, of course, there's always things that you're going to go in there and modify something or make it more vulnerable out there, let's say cybersecurity oriented and the like. And then, the other thing might be is somehow we're going to have a bad patient experience with it, or even a bad clinician care practitioner experience into that, and it could be things due to improper maintenance and the likes.
Right. Do you think it just comes down to money, Perry?
No, I don't. I think, but it's part of it, right? Because if it wasn't part of it, it wouldn't be taking the paths that it does. What I think our community has to understand, though, is that we want to believe that the whole thing is about money, right? Because that's a good position for us to have, right? You can galvanize people behind that. You're like, oh, you monopoly people and this, that, and the other. So is money at play? Of course, money's at play, right? Anytime it ends up in the legislative branch, money is at play, right? So I don't want to be, Pollyanna about it either. But I think we have to understand there are core issues.
So do you see this as a bipartisan issue on the floor with legislators?
No, it's partisan. But partisan takes different forms depending on what we're talking about in the debate. But there are views, both valid on both sides of the party, and it's this, well, I think this is a microcosm of the larger issue, right? Which is, how do you go back and really have true debate and how to solve a problem?
I think you're right, Perry. I think it needs to be more collaborative. So how do we get the OEMs to sit down with the HTM leaders and the ISOs of the world to collaborate? How do we get them all at one table?
Yeah, I think that's the $64 million question, right? And what I would like to try to go back to is what one of the outcomes was in the 2018 FDA workshop, right? They had this notion of like that collaborating community that I talked about earlier. And I think we need to go back to that. But even to get to that point, we have to have and develop, I think, get pretty formal about it and actually develop a charter for what the collaborating community is going to be and what its objectives really are. We'll find if we make this about patient-centered care, and that's actually where it needs to begin, and then the negotiation is as well, I have these needs. And this is why I have these needs, because the patient has these needs and I'm an advocate for the patient. And the manufacturer looks at it and goes, well, I have these needs, right? There is intellectual property there. There are things in here that I need to be able to protect, right? From a market perspective. And I need to be able to do that from international perspectives and security oriented perspectives and a whole host of other things that frankly, from me as a care provider, I'm not thinking of those things, right?
Right now with the biomed community, because that's who our audience is, right? What do you suggest that they could do to help? How can they get more involved? Should they get involved? What's your opinion on that, Perry?
Absolutely, we need to be involved in some ways to do that. The public interest research group is a good place to start with that. They have a lot of letters and petitions that you can go out even on an individual basis, right, and be a part of, right, that will support positions that are more favorable, I think, in the interest of patient care. And you'll know I use those words deliberately. You're not going to hear me go, well, it'll make our jobs easier, or we can get, I don't care about that. It's patient care. Along with that, hospital leadership, supply chain. So maybe you as the individual biomed saying, well, what power do I have, right? I'm just one person. Sound like a familiar argument. I'm just one guy. What does my vote mean? Right. Well, right. So get with your hospital leadership, get with supply chain. If you have government affairs people in your organization, get with them. They can't support you if they don't know that it's there. So explain to them, here's the data. What are the benefits really of this, right? Because they can speak up for you. And if you're not feeling too excited about going that route or a little skittish about that, you have state associations, right? Our state biomed associations. If you don't have one in your state, look to the next one in the region. Look at the American College of Clinical Engineering, right? They will have very different ways that you can promote advocacy, right, around this particular topic. So the bottom line is just to participate and get involved.
But I'm going to ask you one final question. We're using this on every episode. What's your wow word, your word of wisdom?
What I would like everybody to think of with right to repair, or even if you're not into right to repair, but this debate is important to you, is patient-centered care. It doesn't come up in any of the language. It's not in any of the bills. It's hardly ever used when one side argues relative to the other and vice versa. We are missing the entire point. Because if we focused on that, it requires the kind of collaboration ultimately that they seek. Because the reality is there isn't enough of us in these individual little silos to make this work. We need the collective body to make it happen. Now we've just got to figure out how to do it. We need to honor the things that each side brings to the table and work to solve for it. Patient-centered care would be my, well, I guess it's 3 words, but just
That's
pretend they have a hyphen in them.
That's okay. That works for today. And I think that that goes right back to that analogy of mom and dad need to get along to bring up that kid the most positive, you know, well-being, cared for child. And that's what we need with our patients, right? That's why we're all here. Well, it's been great talking to you today, and we appreciate you coming on as a guest. It's always a pleasure to see your smiling face. So have a great weekend, and we wish you the best, Perry.
Okay. And you have a great weekend as well. It was a pleasure being a part of this. Appreciate the invitation in there. Hopefully there's something of value. I think that's all we hope for any of these things, is that it makes you think a little bit. And like I said, hopefully my perspective, it's not the routine. It'll make us think a little bit. I'm a big proponent, again, everybody's got a little bit right in the argument, and that's usually not how most people approach this. So I hope I'm throwing out olive branches to all of our OEM partners. Hey, come back to the table, sit down, let's figure it out.
Thank you, Al, David, and Mike for a great presentation. If you enjoyed today's episode, you might enjoy our ongoing webinar series, Webinar Wednesday. You can find a calendar of upcoming live webinars as well as an archive of on-demand webinars at WebinarWednesday.live. To obtain your certificate for 1 CE credit from the ACI, please remember to click the link located below this podcast title to complete today's survey. If you have any questions, you can reach us at webinar@mdpublishing.com.